Glaucoma suspects are people who have signs or risk factors for glaucoma but still have normal vision tests. For example, a person might have high eye pressure or a suspicious-looking optic nerve at the back of the eye. Doctors say a glaucoma suspect is someone with one or more clinical features or risk factors of future optic nerve damage. Being a suspect means careful monitoring, not that vision is lost yet. Glaucoma is often called a silent thief of sight. It quietly damages the optic nerve before any vision loss shows up. Structural damage means actual changes in the optic nerve or its fibers. Vision loss on a visual field test means those changes have started affecting what you see. In most cases, scans of the eye, like OCT scans, can see nerve thinning before a patient notices any vision change. Experts note that glaucoma damage usually remains asymptomatic until a lot of damage is done. In fact, many studies find that structural changes in the nerve can be seen years before a visual field test shows problems. In simple terms, imaging scans can detect early nerve damage before it hurts your eyesight. Microvascular dropout and beta-zone parapapillary atrophy are scan findings eye doctors watch. Microvascular dropout refers to areas where tiny blood vessels around the optic nerve are missing. On special scans called OCT-angiograms, OCTA, these spots look like patches with no blood flow. For instance, researchers describe it as a complete focal loss of microvasculature in the tissue around the nerve. In plain language, imagine there's a map of blood vessels feeding the nerve, and small sections of that map suddenly have big gaps. Those gaps are microvascular dropout. Beta-zone parapapillary atrophy, beta-zone PPA, is an area of thinning just next to the optic nerve head. The retina there has lost some of its pigment and cells. In doctors' terms, zone BEPA PPA is where you can actually see the white sclera, the eye's white, and choroidal blood vessels because the retinal layers are gone. Put simply, it's like a bare patch around the nerve where normal retina tissue has worn away. There is also an alpha zone farther out that has irregular pigment, but beta zone is the inner ring closest to the nerve. In glaucoma patients, a larger beta zone often means more nerve damage. The March 17, 2026 study focused on glaucoma suspects and early, preperimetric glaucoma, people who show early signs on scans but still have normal visual fields. It found that 2 scan changes may predict future optic nerve damage even before vision tests change. Patients whose scans showed microvascular dropout or an enlarging beta-zone atrophy tended to have optic nerve thinning on later exams. In other words, these eyes were more likely to show structural progression on follow-up. This matches past research. For example, one study found that larger beta-zone PPA at baseline led to faster nerve fiber loss over time. In the glaucoma suspect study, eyes with either microvessel dropout or growing beta-zone atrophy had more nerve fiber thinning later on, suggesting these could be early warning markers. Because structural changes often come before symptoms, these findings matter. If doctors know a patient has microvascular dropout or worsening beta-zone atrophy on a scan, it could mean glaucoma damage is brewing. For now, this is still new research, but it hints that such markers might help catch glaucoma earlier, before the usual vision tests turn bad. For patients, this means that advanced imaging like OCT-angiography could eventually give an earlier heads up. In fact, one long-term study showed that about half of glaucoma suspect eyes had significant loss of nerve fibers or blood flow over a few years. And often the blood flow loss happened first. Could this help doctors catch worsening disease earlier? Possibly. Today, eye doctors monitor suspects by regular scans and visual fields. If new markers, like vessel dropout or PPA changes, reliably signal early damage, doctors might act sooner. For instance, if a glaucoma suspect's OCTA scan shows missing vessels around the nerve, the doctor might watch more closely or start treatment earlier, even if the vision test is still normal. This could help protect vision by slowing disease before it causes vision loss. However, it's important to be realistic. These scan markers are one piece of the puzzle. Even though studies suggest they predict damage, they aren't perfect. Not every eye with a small vessel gap or a bigger atrophy zone will actually lose vision. They may tip doctors off that something is changing, but they don't guarantee vision loss is coming. For now, doctors will likely use these findings to flag eyes that need closer attention. not to make immediate treatment changes on their own. Why early warning markers still need careful interpretation. Any new test or marker must be interpreted carefully. First, imaging results can vary between machines and patients. What looks like a little vessel loss on one scan might be noise or normal variation. There's also overlap between healthy eyes and suspect eyes. Some patients without glaucoma can have mild PPA or changes in blood flow. Experts caution that one study's results cannot be generalized to the whole glaucoma continuum and to all glaucoma patients. In other words, these findings are a clue, not a definite answer. Second, even if a marker is present, doctors need to weigh it against other risk factors, like age, eye pressure, family history. It's still early research. Guidelines haven't changed yet. Patients shouldn't worry that every scan finding means inevitable glaucoma. Many glaucoma suspects never develop vision loss. Instead, these markers would become part of a bigger picture. As more research comes in, doctors will learn exactly how much weight to give them. Until then, they are interesting clues that warrant attention, but not automatic alarm bells. What glaucoma suspects may want to ask about scan results. If you've been told you're a glaucoma suspect, it's reasonable to ask your eye doctor questions about these new findings. For example, do my scans show any microvascular dropout or beta-zone atrophy? If you've had an OCT angiography exam, ask if the doctor sees any focal loss of capillaries or changes in the parapapillary region. What do those scan findings mean for me? Discuss how significant any changes are. Ask if they change how often you should be checked. Should I get special imaging like OCTA? If you've only had regular OCT scans, you might ask whether adding OCT-angiography, which shows blood vessels, is helpful or available. How often should we recheck imaging and fields? If you have these early markers, your doctor might suggest more frequent monitoring of your optic nerve and visual field. Does this influence treatment now? Usually, glaucoma suspects don't start eye pressure medicines unless damage is seen. Still, if you're anxious, ask if preventive treatment should be considered or if you just need closer follow-up. Staying informed and asking about your scan results is wise. It shows you're engaged in your eye health. Remember, these are new research ideas. Your doctor will combine them with your overall risk to make the best plan for monitoring or treatment. References. The concepts here are based on recent glaucoma research and reviews. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.